If you've worked in healthcare for more than a single day, you intimately are aware of Murphy's Law. And that is essentially, for us, anything that can go wrong, will go wrong, and has gone wrong. It's healthcare. A lot of time reacting to things that have already gone wrong. But today I want to talk about how to get ahead of Murphy. I want to introduce you to a tool called FMEA, Failure Mode and Effects Analysis. And I know it sounds a mouthful, but it's actually very, very simple as a concept. It is a systematic way of asking what if. Things, what if the medication label is misread? What if the power goes out during the surgery? What if communication handoff doesn't happen or is missed? So, full disclosure, let me know here that FMEA actually started in the US military in the 1940s and became famous with NASA. So, think about it. When you are putting human beings onto a rocket ship and shooting them off into space to go to the moon, you can't afford to just learn from your mistakes after the fact. You have to predict the mistakes before they happen. Anticipate the issues before you're faced with them so that you can position yourself to mitigate them as much as possible or eliminate those issues. So from space travel, it moved into the auto industry, thank you Ford, and eventually it found its way into the US healthcare system today. So today the Joint Commission and the safety organizations around the world use FMEA to help us shift from reactive to proactive. So instead of just fixing problems as they come up, running around like a chicken with his head cut off, we are being proactive and we are addressing problems before they occur. Now, just to let you know, in order to do one of these FMEAs, this is typically done in a group with a number of stakeholders, but it's important for the stakeholders to have an intimate knowledge and understanding what is going on and the factors that affects them. Because the FMEA is limited to the institution's ability to identify what can go wrong before it does. So if you have no idea, for example, we're in healthcare here, right? One of the problems is that you collect blood cultures and the patient goes home. You anticipate that blood cultures are going to be clear, even though you send the patient home, then all of a sudden the blood culture pings you back and you know that it is contamination. You have to call that patient in to draw another blood culture. But what ends up happening is the organization, whoever the payer is, has to absorb that cost. You have a major delay. You have a loaded situation out there in the wild, and you don't know if you're going to be able to reach that patient in time to have them come back for a redraw. If you have ever done a full FMEA, you know that this process can get intense. It involves RPN scores, severity rankings, and massive, delicious, beautiful spreadsheets, which I love. But while these spreadsheets are beautiful and powerful, they aren't always the best way to get the team thinking together. So when I'm working with a diverse group, clinicians, nurses, admission staff, billing and coding professionals, all the king's horses and all the king's men, I don't want the heads to be buried in spreadsheets. I really want their eyes on the problem. And this is where my lovely friend, the Fishbone Diagram, comes in. It is also called the cause and effect diagram. This was created by Dr. Ishikawa in the 1960s. He wanted a way to visualize the root causes of the problem instead of just treating the symptoms or the superficial stuff that bubbles up. And this is why it's one of my favorite tools when it comes to healthcare teams. One, it is visual. See that? Would you rather look at this or spreadsheets? Don't ask me because I love spreadsheets. But anyway, it stops the blame game. In healthcare, we love to point fingers at people. But those people are in certain environments, faced with certain pressures and so on. So This really changes it from being Nurse Jane forgot to check this box to putting that issue into a compartment like process, the equipment, the environment, things like that. It reminds us that people are often put in suboptimum systems, and that systems can make a difference. So this is to address systems. This isn't just to address one person, even though you could do a fishbone on one person. And then last but not least, it does, for me, it never ceases to amaze me how folks on the team or around the table are always like, I didn't realize that department did it that way. It moves folks from assumptions, generalizations that might not be based in reality, right, to what actually happens. And it helps us to address those things in a objective way, but it also gives us a lot of insight into what the other contributors are to certain issues, processes, opportunities, and whatnot. So I'm going to show you exactly how this works. We're going to move away from theory and get our hands dirty in the real world. I'm going to use this scenario about maternal health. And we all know that the stakes in maternal health are incredibly high. We're dealing with more than one patient, right? Simultaneously. The environment is high stress, the variables are constantly changing, and it's the perfect place to apply the fishbone because we need to see how equipment, communication, staffing, and all of that intersects to affect patient safety and optimal outcomes. So I have a demonstration partially ready to go, but let's see if we can use this to catch our risk before we get over here to the bedside. So first and foremost, there are some traditional buckets that the fishbone follows, and I will go into those right now. I wish I had like a fatter marker. Okay. So the first one is people. The human factors that contribute to this. I need to explain a little bit about what the problem is that we're trying to solve. So the problem that I'm trying to solve, or the issue that I'm trying to prevent, are delays in care in maternal health. Anyone who has had a pregnancy that is high risk probably knows exactly what I'm talking about right now. So, first category is manpower. Not horsepower, manpower. Next, we have methods, and I'm going to go into what each of these mean. Next, we have machines. So this is your equipment, your technology. Then we have our materials, and this is specifically how we are measuring this, how we are measuring the care delays. In this case, what manpower issues or factors contribute to care delays? What methods or policies, procedures contribute to care delays? What machines, technology contributes to delays in care? What materials, physical stuff that you can touch, contributes to care delays? What measurement can we use? What measurement pertains to care delays? And then lastly, last but not least, environment. So this gets really delicious because environment, actually, a lot of times when I'm doing these, folks will say something like, I'll take stuff from the audience and I will open-end it, right? So for example, I will say, what things are contributing to care delays? And I will let folks fire at will and let me know what, with their knowledge and experience, what contributes to these care delays. And as they say them, I will list them here, but I don't have a live audience right now. I will list them here and then attribute them to the relevant section. And that's how we go. We often find that measurement and methods are often where teams get stuck, and that is where we have a wonderful opportunity to do a little bit of root cause analysis. For example, if someone says, we didn't weigh the blood, again, I'm talking about OB here, we didn't weigh the blood, I would ask, is it because you didn't have access to a scale that would allow you to weigh that blood in a timely manner? So we didn't weigh the blood. There are many parts of that. There's a manpower part of it, material part of it, machine part of it, because you can weigh the blood, but if it doesn't get documented into the EHR or electronic health record, then it didn't happen, right? And then there's also the fishbone for a number of reasons, because it really illuminates things. I like to do these in my head too. For example, let's talk about this recent case where a young lady went into the emergency department. She was labor. She ended up turned away from the emergency department and giving birth on the side of a highway to her child. It was like less than 10 minutes later. I think it was like 8 minutes later. This sort of thing happens all the time, which is why I do not believe or hesitate to assume that these rampant issues are the result of people just being naughty people. Now, there are bad actors out there, obviously, in this world, but sometimes things can potentially be addressed within a system. But before I go into that, I'm going to put this under manpower. So I'm actually going to list out some of these factors here. I'm going to list them out like manpower, methods, machines, where typically it's rapid fire and we go around. Okay, so first and foremost, with this issue with delays, okay, we have, dare I say it, bias. And this is implicit. That is something that would fall under manpower. Do you see how this is working? Under manpower, the human factors that could possibly contribute or that pertain to care delays in maternal health, right? This is one of them. I'll give 4. Next, I'm gonna say hierarchy. Because in some settings, we have wonderful young nurses who come out of nursing school and might even be in La La Land or Disenchanted. But we have nurses that come out of nursing school that hesitate to escalate concerns to the provider. So the nurse might have the sixth sense and go like, something's going wrong here. I don't like this. This does not sit with me. And instead, if it's a new nurse, they might not even feel that they should ask certain questions to the patient or to the provider. Maybe it's nighttime. Maybe the provider that you're dealing with is Oscar the Grouch, and you don't want to page them in the middle of the night to be like, hey, I think, or maybe they don't have senior staff around them or an educator that's available at that crux time, right, to help them mull over what the alarm bells are in their head that they're thinking. So hierarchical power. There's also patient health literacy. So this pertains to the patient because it takes 2 to tango, or more than one person to tango. There are multiple parts of this. Let me say this. So when it comes to manpower and healthcare, this pertains to every single member. Like anything under here can pertain to any member of the care team. Who is a member of the care team? The patient is a member of the care team. So it is totally appropriate And it makes sense that if the patient is a member of the care team, the leader of the care team, the most important member of the care team, right? Because they are everywhere, every appointment with every specialist, every touch point we have, the patient is there anyway. So this pertains to the health literacy of the patient. Let's do staffing ratios. Let's do burnout. Actually, I'll stop there. There are a million things that can go here. As you can see, this can go on forever. And this is why outside of the fishbone, when you're dealing with traditional FMEAs, it's spreadsheets and spreadsheets and spreadsheets because there's so much. All of these things, for example, staffing. Staffing in itself warrants its own root cause analysis. Burnout in and of itself warrants its own root cause analysis, but we are gonna stay pretty high level here. But now you can see why this process can be both insightful and fun at the same time. All right, so now let's go into methods. Again, this can go on till Timbuktu. It really can. That is the beautiful part about it, or one of the beautiful parts about it, right? Let's go into methods. Under methods, I'm going to say these are rules, protocols, yeah, things like that. Like this is how things are traditionally done in this setting. One thing that could lead to that delay could be triage algorithms. And to this point, you can add something here where, for example, say you're at a health system and your your ER or your LDRP unit does not have an algorithm or workflow or protocol for triage, to support triage. Perhaps one of your stakeholders in the group is like, we should have some triage algorithms. And everyone else is like, okay, maybe. 50% are like, yeah, that's a good idea. I could explore that. Go ahead and put that up there. So these don't have to be things that you have. You can also be naming the absence of something that's desirable. Discharge procedure, and again, that right there, you can get it. Handoff communication. Okay, and then of course, scheduling, right? So, and then I like to add on top of scheduling, bed management expectation or length of stay type of thing. I put it as LOS. Can you see that? Okay, now I'm going to move on to machines. This is where things get delicious. Let's get into machines. Before I move on to machines, can you see how this pertains to manpower? These little factors, bias, hierarchy, health literacy, staffing, burnout, can contribute to care delays in maternal health. Can you see how lack of or quality of triage algorithms, discharge processes, handoff rules, scheduling processes, and length of stay protocols or whatever can contribute to care delays in maternal health? All right, let's move on to machines. Let's talk about the electronic health record. First and foremost, if you do not have the EHR on here in healthcare, do not know what to say. An issue that is patient-facing or as close to the patient as delays in the patient's own care. EHR should always be something that we are willing to scrutinize, to respect. When I say respect, I mean look again at, because there are typically some levers that can be pulled in this area, and it gets really exciting. All right, let's do machines. Let's do fetal monitoring. Let's do blood pressure cuffs. Let's do emergency equipment like a hemorrhage kit or hemorrhage cart. Okay, so this is typically in labor and delivery, obviously. But again, here, I wouldn't even say just EHR, but you'll see here in a minute how this shakes out. Now, let's get into measurement and data metrics. How are we going to measure success? How are we going to identify where we are? How can we measure our proximity to improvement in this area? One issue can be that we do not have a means that has been identified yet of measuring care delays, because we're busy taking care of the patient and doing all of this stuff. Measurement of care delays is not like a billing requirement, right? We can still take care of patients without measuring care delays. However, when we're dealing with care delays, it's very important for us to be able to measure it. So this is first and foremost, regardless of what this is over here, I always say, do we have a means of measuring it? Or how is this measured? And it typically ends up that we don't have a way of measuring this appropriately. We don't have a line of sight into that. Imagine if we had an initiative and we run off with an initiative regarding care delays, because it sounds great and it's the newest thing out of XYZ journal, and we want to be the best and we want to do what industry leaders are doing to address this, but we don't have an intrinsic or an internal means of measuring that. We won't even know if we sink or swim, essentially, in that scenario. So let's get into measurement and data and metrics. Do we have a way of measuring care delays? So first I'm going to say how measure. I have a few examples, some insights to share, but right now I'm just listing these factors out. We can go into vital signs and the timing. I love using vital signs because when is it not used? Maybe in inpatient psych, it might not be used, but every encounter in healthcare that I know of, maybe home health, maybe not. Most encounters that you have with a specialist, with your PCP, inpatient, outpatient, well, maybe not your dentist. You're getting your blood pressure taken. It's a great way of having data sets to quantify progress with blood pressure, one, but two, to quantify timing. Quantify the time or the length of time between this visit with this assigned blood pressure to the visit, and then this visit with this assigned blood pressure. See, there are ways of working around things. If you're able to confirm that a blood pressure is taken at this point of every single appointment the patient has, then you will be able to quantify vital sign triggers, right? Let's do quantification, and let's do lab turnaround. There's lab turnaround. And then I love me some ED metrics. There's ED metrics, door to provider, for example, pertaining to the emergency department. And then you also have LOS / bed management. You also have messages in there are time stamped. You also have a fax receipt that you get, things like that. So it doesn't have to be, these give you data insights or can provide insights into what is causing care delays. I promise you, I could probably go on forever about how we can measure or use certain metrics to measure delays in care, but for the purposes of this video, y'all get it. All right, I'm gonna go into measurement. Let's do materials. So handouts. And I would say that the handouts would include your after visit summary. So these are handouts that pertain to the patient. Here's another one. You see how I underlined handoff communication? A lot of units. Handoff communication is done on a standard sheet of paper, on a piece of paper that unit might have iterated on a template, a standardized template, where they're just like, okay, this is the information that I need to know, the down and dirty. These are the categories I need to know. I need to know, for example, how many babies, the age, what prior medical history, can she have blood products? That's a big one because not everyone can have blood products. Is she vaccinated? Hepatitis, does she have, or what was her strep test or her hepatitis test say? I call it the report sheet of death. I cannot stand these things, but that is just my subjective opinion. I grew to dislike having these standardized sheets when I was a young nurse. I still am. But when I was a young nurse in the float pool, because when I was in float pool, obviously I floated to multiple units. So the ortho unit might have their own standardized sheet. The med-surg unit might have their own. You have the ICU, you have the emergency department didn't have one. You might have the step-down unit, you might have the observation unit. All of these units had their own proprietary thing that worked for them. But what got me about that is the fact that I am neurodivergent. I'm neurodivergent, okay? My brain does not work like that. My brain does not work in your little boxes. I need to see the information a certain way for me to quickly process it. And what really helped me was not using handoff communication, walking around with papers folded by fourths and fifths, origami style in my pocket, but I would have one piece of paper and I was able to shorthand. I have been recognized on multiple occasions for the quality of my handoff communication. And it's ironic because the educators that reached out to me about and commented and spoke to my supervisors about the quality of my handoff communication were the same educators that were initially pushing and encouraging and promoting the use of a standardized report sheet. But chances are there is more nuance and more tacit context that needs to be passed over that does not fit in the nice, neat little boxes. Not only that, but the order of operations, how they would go through the list. If this is the report sheet, people will go from here to here. What if the most important, the most critical, time-sensitive bit of information was here? Why the heck would I tell that to the next nurse coming on last? Why would that be the last thing that I tell them? Because of the way that the paper was formed? Because of the way everyone else does the report? I'm gonna give you a heads up first and foremost. Anyway, let's hand off communication. Hand off paper or form or template, okay? I'm going to touch on this again. You see how I keep touching on handoff? I'm gonna touch on it again over here too. Handoff under environment, and you're gonna see why in a hot second. Handoff materials could be, those are handouts, that pertains to handouts. Something as simple as a remote patient monitoring log. If you're doing those things by paper, obviously we should be doing, these things should be automated. When it comes to blood pressure and blood sugar measurement, continuous glucose monitoring has been around for a bit. And then environment, which I love. Let's get into environment. I want you guys to understand what I'm about to say. And I'm speaking as a nurse. I'm not speaking as a doctor or the owner of a hospital or the construction company that has revamped your units and made them hotel-like. Once upon a time, in maternal health, we know not everybody births in the hospital, especially historically. Not everyone births in the hospital. But in the hospital, there were wards, things like wards, where patients were separated by curtains. Now, however we feel about that, because yes, people want privacy, I'm not talking trash about that. What I'm getting into is that is the past and that was the experience. Think about this. When we're talking about care delays, we're talking about areas where care is slower than we would like or than was historically. I'm saying this because in a ward setting, nobody wants wards anymore. In a setting, a nurse could move from patient to patient to patient quickly. Don't forget hand hygiene. Nowadays, it's not like that. I am yet to step onto a modern LDRP unit, layout of the floor to have only one hallway. Imagine you have patient here, you have patient here, you have patient here. These are hallways. Wall. You see what I'm saying? Wall. You see? Walls. And then your patients there and there. There are other patients in between, but for some reason, maybe we're gonna claim that we staff by acuity. For some reason, you're assigned to this patient in this hall, this patient in this hall, and this patient down that hall. Can we see how the speed, the velocity of care can be slowed down, or it's slower here than in a traditional ward system? Again, I'm not trying to say we should go back to the wards, but this is an example of how environment can really affect care delays. And that's in the acute inpatient world and outside. You can name things in the environment that contribute to the care delays, even if they're not anything that are in your span of control. I am not going to say, if we say hospital layout or floor layout, I'm not gonna say, okay, call in your construction crew. It's time to take down all these walls. We want an open room, an open floor plan, an open concept. We're gonna turn that into, no, we're not gonna do that. But we can acknowledge this. And actually, with every single one of these factors, again, root cause analysis can be done here, ask why 5 times or whatever, and we can see that maybe if we can't change the layout, the physical layout of the hospital, maybe there's some levers that we can pull so that we can consolidate nursing assignments more geographically. Another environment could be literal distance between providers or between the patient and their provider. Proximity of care, offices. So there's that, because it does contribute. I'll give you an example. Say you have a patient that is pregnant. The patient experiences spotting. Say the patient's 24 weeks. Because typically you would go to see your OB or your midwife. If it's an emergency, you're told to go to the emergency department. If you're past 26 weeks, then automatically go straight to the ED, and then they call your OB typically, right? But here, say you have a patient that's 24, 25 weeks. Their OB is like, yes, I will see you. But imagine if that OB's office is literally 2 hours away from the patient's residence. Now they are spotting, okay? And you can do a simple test to check for residual, of course. But imagine, what's this mama gonna do? Is she going to traverse 2 hours each way in the frigid snow? Or is she more likely to go to the emergency department? I wonder. Now, what happens when the mom goes to the emergency department? A lot of things can happen, but what ends up happening in the provider's inbox or provider's notifications is, you say this is a stack of papers. Okay, this is when she called, the patient called you here. Now that's covered up by an ED message or an ED visit. If she's not able to reach that provider and she ends up going to the ED instead, when the provider goes in to take a look at the patient, their most recent appointment or touch point wasn't their last appointment with you, it was with the ED instead. And so now you have to look up all of this documentation and gather the context of what happened in that ED so that you can continue on with the care for that patient. Do you see what I'm saying? Yes, geography and radical honesty based off of common sense and tacit knowledge belong in here. Definitely contribute to delays in care. So even though they were seen by the emergency department, it doesn't necessarily mean that everything was satisfied in the emergency department. What if the emergency department that the mom went to doesn't have any labor and delivery obstetric staff at that ED? What if? Because actually that's becoming a reality. We are seeing hospitals close down their LDRP, their whole obstetrics, their whole maternal care offering. And so you're gonna have more and more ED, because EDs aren't gonna go away. You're gonna have EDs that likely are of closer proximity in these healthcare deserts, especially maternal care deserts, right, than the specialist. And so that literally contributes or can contribute to care delays, just in the way that that patient pulls up in the electronic health record. So yes, there's that. And then of course there is nights, because I don't care what anybody says, the way things roll at night is not the way things roll in the daytime. I am sorry. Night is off the chain, okay? And then of course there's weekends. So there's outside of business hours. And when you're in a critical industry, dealing with obstetrics, right? And offices are closed on the weekends or they're closed at night, I promise you those closures are likely to contribute to care delays. Now, I'm not saying to unearth everything that you have and say, no, Dr. Smith, I want you to work 24/7. No, that's not what I'm saying. But I am saying, please be mindful of what can contribute. So this is what we have here. I'm gonna do another video, I'm sure. All right, but this right here is a beautiful thing. You see how much I love it? It's awesome, because what we have done is we have gone from identifying an issue, care delays in maternal health, and haphazardly, because this is not a live environment, but haphazardly have gone through, outlined different factors, manpower, the methods, the policies, procedures, the rules, the machines that can contribute. All of these things are factors that can contribute care delays, right? And then we took each of these and we drilled down. We have at least, in each of these, we have at least 4 points in each of these. It can get super fun. There's so much that you can do. Actually, I might leave this. Yeah, maybe I'll leave this up. Hold on, let me take a picture of it real quick. And then do a part 2 of this video, because it gets really, really fun. It gets really, really fun because what you can do, again, is you can go in with your team in the same setting. I hope that you got them lunch, right? And you can cross out or touch on things that are completely out of your span of control. You've identified and just, there is nothing we can do about that. You can cross it out. I don't recommend that you do that, but you can. Look at these things and be, okay, what are the top 3 factors that are likely to contribute the most out of all of these? You can all vote or whatever. And you can take the issue, the problem list, and then you can have so much fun. You can have a party, brainstorming, researching evidence-based practice, and collaborating with other folks, other stakeholders, to see how can we address this issue. So remedies, okay? Now, again, this is like a wish list, a fancy thing. Do not get bogged down into fixing every single one of these issues before you move forward with something. In a perfect world, yes, you could, but we're not in a perfect world yet. And this is a world without leveraging technology like agentic AI, which is going to be an absolute game changer, mind you. But yes, there are certain things in here that are low-hanging fruit. And I always say, don't look at these things and consider them all to be weighted the same. Some things, there's one that's immediate. Later on, this matrix right here, right? Can you see that? Okay. Now, later, or urgent, non-urgent. And then this one would be easy and difficult. You can even go and be like, okay, that handoff paper form that Lauren can't stand. Is that an urgent issue? Is it something that's easy to address? Perhaps we move that here, because then we know that that's something that we can just do simply relative to addressing these other things. So that's an example of that. Anyway, I hope that was illuminating and as fun for you as it was for me, because I love this stuff. Ask questions on the bottom of this. These are the sort of exercises that I love to invite folks in on to do for a number of reasons. One of the reasons is sometimes if you find a solution, sometimes the right solution to one issue can be a silver bullet that addresses multiple things. For example, you see it here, method, handoff communication. You see handoff communication is under methods. Handoff paper is under materials. You see how I have a vendetta, right? And then handoff is also in environment. So imagine if you're able to optimize that handoff in a low lift way immediately, how that could potentially move the needle here. And you will know based off of how you measured it. But you have to make sure that you measure your actual outcome. You measure the actual delays and not just your actions. Don't just measure your interventions. Measure the actual patient experience.
Look out for new updates.